Okay, so you know Dario works for the company, so he would like you to buy this machine. I do not work for the company, so I'm going to try to give you a more critical overview of my last few years of experience with this machine. And I started a few months ago just thinking that this would be a talk about my experience, but it's kind of expanded over time as I've talked to lots of people to gather information, which will become clear. So I started titling this intraoperative radiation therapy, Quicker, Better, Cheaper. But now I've drawn a circle around better and put a question mark because, to be honest with you, I don't know that it's better. I know that it's quicker. I know that it's cheaper. I don't know that it's better than whole breast other than that it's faster. There's no doubt that if it were equivalent and faster, it would be better. If it caused less side effects, it would probably be better. But let me leave a circle and a question mark, and we'll come back to this toward the end of this talk. So we've already defined that what we're going to talk about is radiation therapy done in the operating room with a single dose. You can use radiation therapy as a boost and then add whole breast radiation therapy. That's been done a lot in Europe, and that really works well. But I'm not going to speak about that today. I'm just going to speak about whole breast treatment in a single dose, or the entire treatment in a single dose. So here's the outline of what I think I'm going to cover. I'm going to talk about the rationale for doing this. Does it make sense? And then I spent the last couple of months reviewing Elliott and Target data. I'm going to review those data with you, the latest that's available in the world. Then I'll talk about the protocol we set up at Hoag. I'll talk about some early complications that we had that were significant. Then I'll talk about all kinds of cases that we've done, regular standard cases, some oncoplastic cases, the augmented patient, et cetera. I'll go over the results with you, and then we'll talk about perhaps getting some kind of an IORT program in your hospital, how difficult it might or might not be. So let's start with the rationale for intraoperative radiation therapy. And I think we all owe a lot to Professor Veronese. He's the guy who really who got tired of, in his words, mutilating breasts. He was the first guy to say radical mastectomies are horrible, they mutilate breasts, let's do something less than that. He spent a number of years getting a conservative approach approved and finally done, and was really the first guy in the world to publish a paper that proved that breast conservation was as good as a mastectomy. He also, for a long time, felt that whole breast radiation therapy was also a mutilating, excessive treatment. And he looked at his own data from the first Milan trial, and he found there was only maybe about a 15% local recurrence rate, but when they recurred, almost all the recurrences, in this case, 86% of the recurrences were at or near the primary lesion. So it made a great deal of sense for him to start thinking about just radiating one part of the breast. If we're operating on one part, why not radiate one part? That made me look at our own data, and I just recently ran our data, and I have 822 patients in my own database that were treated with excision alone, a little bit over 700 DCIS patients and 110 or so invasive cancer patients who refused radiation therapy. And lo and behold, when they recurred, 88% of them recurred at or near the primary, and lots of other people in the world have the same experience. So it makes sense for us to try to figure out how we can treat one part of the breast rather than the whole breast. So the old paradigm of treating the whole breast with surgery and radiation therapy is going away, and we're going to have a new paradigm. And the new paradigm is really let's treat the part with the cancer, and in other words, less is going to be more in this particular case. So we already have some breast experience with this kind of stuff, with catheters, with balloons, with combination balloon catheters, with 3D conformal, and there's some good experience with this, and this works. There are very low recurrence rates at 5 years, but the problem, it's kind of inconvenient. You have to be very expert to put interstitial catheters in. If you put these balloons or balloon catheters in, they're in for 5 days. You got to treat twice a day. You get seroma cavities. You get thick walls around them that last for a long time. You get infections. So while this is good, it's maybe better than whole breast, it's not really the answer that we were looking for. So they all take 5 days, and occasionally they'll miss the target. You'll put one of these balloons in, you won't even get it in the right place. So it's really nice here where the surgeon is looking at a big hole in the breast. We know exactly the right target. So we could really get that radiation therapy right there if we had a tool. And it's right in front of us. So we'd like to irradiate with a single dose and a precise target. And that's why intraoperative radiation therapy is very appealing when you compare it to external beam or whole breast radiation therapy, if you think about it. First of all, it's going to take less time. It's going to take 30 minutes or thereabouts rather than 30 days. We're told that there are less side effects. We'll look at that. We're told that there's less damage to the surrounding structures. We're told that there's better cosmesis. We're told that it costs less. We're told that it's clearly more convenient. It's going to eliminate the problems with age and distance. We have lots of older patients who never quite finished their whole breast radiation therapy. We have people who live far away who say, there's no way I'm going to make it in for 5 or 6 weeks. I prefer a mastectomy. And this way we'll bring them back to the breast preservation table, so it's clearly going to be more convenient. And we're even told in the Lancet in 2010 that Target has equal results to whole breast radiation therapy. So how many believe that? Nobody believes it? Silverstein Fellows, do you believe it? Silverstein Fellows, how many? They've all done, there are 3 fellows here who've done at least 10 of these cases. You should put your hands up so they know who you are. Come on, Catherine. Okay, so you should talk to them afterwards and see what their experience is and see whether they like it. So look, here's a whole list of fantastic things, right? So why isn't everybody doing it? Hardly anybody's doing it, to be honest with you. Here's some of the reasons. First of all, the data is short term. Second of all, we have just heard some 5-year data. Veronesi's data has been released at the ESTRO meetings 10 days ago in Geneva, and we heard 5-year data in San Antonio on Target. I'm going to review both of those for you, but I would say that what I'm going to say now is that the results are not equal. They may not be bad enough to abandon this, that they're not equal. But the most important result, or the most important reason, is that reimbursement is poor. Ask this woman. So there have been 150,000 brachytherapies with balloons or balloon catheters or things like that, and there's no prospective randomized data on these systems. So it leads me to believe the reason this has taken off is that, yeah, it's convenient and all that, but the most important thing, it's well compensated. And that probably is the reason that you could get 150,000 cases like this done. So let's change paces and look at the data critically. And I have tormented my fellow Trish for the last 2 months. We've been every day talking about these data and not quite knowing what they mean. So there's a lot of spin that goes with this, and it depends who you talk to. The data can be spun to the right, they can be spun to the left. You have to look at it and kind of decide for yourself where you think it's at. So the Elliott trial is Veronesi's trial. He's totally reputable. He started this trial in 2000, finished it in 2007, and didn't publish anything about it because he wanted appropriate long-term follow-up. But Dr. Arecchia, who's the chief of radiation oncology, presented the data that I'm going to show you April 22 in Geneva, Switzerland at the ESTRO meeting. Although there were about 1,300 patients randomized, there were 1,186 patients that were available for evaluation and were presented. And the first thing you'll notice is that they took any infiltrating cancers. They took ductals, they took lobulars. The tumor had to be 25 millimeters or smaller by clinical examination and x-ray, and the patients could be 45 to 75, and that was it. There were no other restrictions on putting patients in this trial. Half the patients got external beam. You see 60 gray. The other half got IORT. And for those of you who aren't familiar, I'll just show you what they do. These are Veronesi's pictures. He kindly gave them to me. He excises the lesion, generally with a quadrant-type resection that you see here, not a little puny excision. And then the chest wall is exposed and protected with a aluminum lead shield. And then the breast tissue is reapproximated over that shield. And then the collimator is brought in, and X-ray therapy is given. And here is Professor Veronesi himself giving a treatment. Now, originally, that collimator was about 4 centimeters. Recently, they figured out that it probably ought to be 6 centimeters to get a wider area. So they've had some evolution in their thinking, but most of these data were accrued with a 4-centimeter collimator. And here are the 5-year results for Elliott, just presented 10 days ago. In the whole breast group, there was less than 1% local recurrence, 0.7%. And in the Elliott group, there was 5.3% recurrence, about 7 times higher. An enormous difference, highly statistically significant, disappointing to some, exciting and positive to others. It depends how you look at this. When I look at it, I say, gee, 5% in 5 years, it's not bad. This is not even a Kaplan-Meier projection. These are absolute numbers. Veronesi's patients have a median follow-up of about 8.5 years, and these are absolute 5-year data. These are correct data. They're not projections. Now, when they started this trial, they made some guesses. They said, we think that the whole breast recurrence rate at 5 years will be 3.5%. We think Elliott will be 7%. We find that acceptable. We think that's what it's going to be. Turns out both of them are better than they expected, only whole breast was a lot better than they expected. Whole breast was dramatically better than they expected. So would this stop anybody in the room from doing IORT? This 5 times difference? Does it scare you? So it's not the whole story. It's not the whole story yet. Haven't gotten there yet. But so just at this, all right, I won't ask any more questions. Let's go a little bit further. Okay, so the next thing, the Veronesi people, they didn't do any additional radiation therapy. For example, if a patient had 4 positive nodes, or if a patient had triple negative tumor, or the tumor actually was 32 millimeters, they didn't add radiation therapy. They kept them in this protocol. Despite all of that, breast cancer survival, overall survival, distant metastatic disease was identical in both arms. Now, this study got started in 2000 before ASTRO defined, in about 2005, 2006, ASTRO defined suitable, cautionary, and unsuitable patients for accelerated partial breast radiation therapy, for balloon brachytherapy. Those definitions were not available in 2000, and so this trial randomized all comers that met the basic tenets that I outlined before. If you, so what it turns out that only 23% of the Veronesi patients were ASTRO suitable, 46% were cautionary, and another 31% were absolutely unsuitable. But if you run this analysis and say, I'm only going to look at the ASTRO suitable, it drops down to 1.5% local recurrence rate. So clearly, you could just select out the patients, and you'd have a much better result. So Dr. Arecchia said that they were going to certainly consider adding radiation therapy to these patients if the tumors were bigger than 2 centimeters, if they were high grade, if they had multiple positive nodes, if they had lymphovascular invasion, all the things that would make them unsuitable candidates. So here's the truth. If you don't like 5.3, you could drop it down by simply saying we're only going to take ASTRO suitable, or ASTRO suitable plus cautionary. It would go up another couple percent. So this is what it would take if you only wanted to do astro-suitable. Here's their actual publication, but it's patients who are 60 and older. They have tumors that are 20 millimeters or smaller. They get margins of 2 millimeters. Astro requires that. No lymphovascular invasion. They have to be unifocal. They can only be ductal. No pure DCIS. No extensive intraductal component. They have to be N0, although they do allow I-positive cases, and a no neoadjuvant. So that's fairly restrictive. It would probably eliminate, 65 or 70% of the patients that we've done in my group. This is a bad slide. I apologize. It's all I could get, but this is the actual Auretia slide with a Kaplan-Meier projection to 9 years for these patients. We have it on good word that this paper has been accepted for the New England Journal and ought to be out within the next month or so. So you'll get the chance to really critically read it and think about it. In terms of adverse effects, in favor of whole breast had less fat necrosis and less skin problems, better wound healing, less keloids. We'd expect that. But in favor of IORT, there was less skin erythema, less dry skin, less hyperpigmentation, less edema, less itching, and perhaps most important, there was less pulmonary fibrosis by a factor of 9 to 1. So there was a lot going for IORT. And even this 5% sort of bad, statistically high result I don't find it particularly alarming, because the way I spin it, I'd say, you know what? If I gave this IORT to 100 women and 5 of them recurred, I still saved 95 people from getting whole breast. I will now deal with these 5 people. I'll re-excise them and I'll give them whole breast radiotherapy. So I don't find this terribly alarming. Now let's move over and we'll talk about intraoperative radiotherapy with these electronic tools. I think I'm one of the few guys in the world who has in-depth experience with both. We have the Zeiss machine at USC, and Dennis Holmes and I did many, many cases between 2006 and 2008. We contributed 55 patients to the Target trial. And then at Hoag, we have the Zoft iCAD system. So these systems are quite different. Veronesi's system is a megavoltage electron system. This is kilovoltage, ortho voltage, low dose, 50 kV, whatever you want to call it. There's a whole list of names that you can call it down there. So here is the system at USC Norris. It's fairly big and bulky. You've got this machine here that generates electrons that go down and hit a goal target that you've heard, and you've heard all about this. There's these spheres that get the breast to conform to it, and you treat around the spheres, and you treat 20 gray to the surface and 5 grays at about 1 centimeter, and here's the entire system set up. Better that Randy Holt goes over all the physics of it. I'm interested in showing you the data that they've published. So here's the 2010 Lancet paper. That was the rage. Everyone thought this was a critical, important paper. And here's what they had at that time. They had 2,232 patients. They had only 25 months of median follow-up. That is very difficult to find in that paper. You have to find it in a little teeny footnote in a table. But there's only 25 months of median follow-up. And then they published 4-year Kaplan-Meier projections. That's not what Veronesi did. These are 4-year Kaplan-Meier projections. And they basically had about a 1% recurrence in each group. There was a 0.25% difference in the two groups. But they were statistically equal with a p-value of 0.41. And this was all the rage, that now this electronic brachytherapy was equivalent. And it got accepted in most places, although there were certainly critical people in the literature. In terms of side effects, the side effects were minor in both groups. They updated it at San Antonio in 2011. There wasn't much change. But in 2012, they just updated it. And here's what happened. In the last 2 years, they continued to accrue patients. There's now 3,451 patients. The median follow-up is now only 29 months. It's not any better. It's 2 years and a few months. That's all it is in terms of median follow-up. And the difference is now 2 percentage points, 1.3% versus 3.3%. And that was statistically significant. The presenters and the target people spun this in a very positive way. This trial was designed as what we call a non-inferiority trial. So we're trying to see whether or not IORT was inferior to whole breast radiation therapy, and they were willing to accept an inferiority of about 2.5%. And they said, it's inferior by 2%. Great, we're within the guidelines. This is fantastic. This was interpreted as a very positive result by some. So let's look at it a little closer. So here's target versus whole breast. There's a 3% difference. The first thing, that target is very different from the Veronese study. Target, if you had bad pathology findings, they irradiated you. You got whole breast radiation. And at least 15%, some people say 20% got whole breast, but at least 15% of the patients got whole breast, but they stay in the target arm. Okay, so the truth is, the target arm would actually be, without that whole breast, if they handled it the way Dr. Veronese handled it, that would be a little bit higher. That might be, 3.8% or some other, it'd be a higher number. As I said, that the Lancet paper only had 25 months of follow-up. The San Antonio recent discussion was 29 months of follow-up. If you look closely in their discussions, only 18% of their patients had 5 years of follow-up compared to Elliott, which has almost all the patients. 95% of the patients have 5 years of follow-up. Here, only 18% have 5 years of follow-up and 29% have 4 years of follow-up. And the slope of the curve, which I'm going to show you in a second, the target slope is much higher, much steeper than the whole breast slope. That is scary for any statistician who looks at the curve. We'll look at that in a second. And everybody who's looked at it is quite sure that target is going to surpass the 2.5% inferiority in a year. So here's that curve. Look at that curve. And here's the slope of that upper curve. Does that look like a curve that's going to stop? I don't think so. I think that curve is going to continue to go up. Now, what Target told us, they said that almost all recurrences occur in the first 2 or 3 years. Well, the truth is, if you look at any radiation therapy study, recurrences occur at a median of about 5 years. So we're just seeing the beginning of the target recurrences. And here's the problem. With only 29 months of median follow-up, you haven't seen nothing yet, okay? There's a whole bunch of patients that have to be seen. And by them adding another 1,200 patients in the last year and a half or so, it weights the study down with a whole bunch of short follow-up patients that have not had any time to recur. So the point is, I think we're concerned about this. I think the numbers are great. I think 3.3% is totally acceptable. A 2% difference is totally acceptable. I'm concerned about the way that curve looks. I think it's going to go up. And the issue is going to be, what are we willing to accept to adopt this type of treatment? Will we accept a 10% recurrence rate, 12%, 9%? I don't know what the right answer is. We can discuss that. I just put a little grid over it if you wanted to just see it a little bit better. Now, Target has something else that they think is really great. Target has less deaths in the target arm. Nobody can really understand this, but they've made a big deal over it, that there are less deaths in the target arm, and they're thinking that whole breast radiation therapy is causing some deaths. Now, I'm not a fan of whole breast radiation therapy, and I think it does cause problems, but I don't think it causes problems in 5 years or 3 years or however long this short-term follow-up is. Nevertheless, they make a big deal over it, and they show these curves, and they show that there's way more cardiovascular deaths in the whole breast radiation therapy. So I don't know what it means, but it's certainly something we should note. And at San Antonio, these were their conclusion slides. They said the absolute difference was only 2%. And that was acceptable. And then I didn't go into any of this stuff, but they also talked, they had two groups. They had one group of patients got surgery and IORT right then and there, and about a third of patients got surgery and IORT 6 weeks later. And the people who got IORT 6 weeks later didn't do as well. They had a higher recurrence rate. So they have another special group. It's called the pre-pathology, which is the people who got surgery and IRT the same time. And if they were PR, progesterone receptor positive, their recurrence rate was only 0.18%. It was almost nil, zero. So we don't quite know what that means. They've kind of sprung these subgroups and this information on us. So we're waiting to see what that happens. Their other conclusion, of course, was that their patients had less deaths. So now those are my look at those two trials, and I'm kind of just left with not knowing whether the glass is half full or half empty. I think this is all exciting stuff. I think, to me, it's in general pretty positive, and I certainly wouldn't abandon thinking about this, but I would be a little more cautious about going forward. Maybe I'll choose my patients a little more carefully now. I'm not sure what I'm going to do, but I think I need to see more target information to really make this exciting. Now let's go over to the Xoft Accent, this machine. So you've heard all about it. I won't spend any time on this, but I'll say one important thing, and that is that this machine has no randomized data. This machine is based on target data. We heard that this machine delivers radiation therapy that's very similar to target. So here's the truth. It's really important to us. If we're in this room and we're interested in this machine, it's important to us that we buy off on target and that we think target makes sense and that it's a good study. That's what's important. And I think a lot of it's good, but I'm concerned about it. Target did some funny things. They got 33 centers. Every center had an option to make certain rules. So one center could allow up to 35 millimeters. Another center might allow 30. One center could have no ink on tumor as a clear margin. Another center might require 5 millimeters of clear margin. Every center could make any rules they wanted. So we hope that when all of this is pushed together, it all evens out and we get an answer that we can believe in. I think we will, but I think we need a little bit more time. So you know, with this machine, it comes with a whole bunch of prepackaged treatment plans. We plug it in based on the size of the balloon and everything we put it in. So let me show you the program that we set up. We started in about 2009, and we wanted to do some kind of an IRB-approved prospective trial. We didn't want to randomize patients into whole breast. That's been done, and we didn't feel we could ever get enough patients to do it. So we decided that we would do a study that would give us answers very quickly and easily. And the study asked a very simple question. Can imaging, with the things that we all use, mammography, ultrasound, and MRI, identify patients that don't need any additional surgery or any additional radiation therapy based on the protocol, on the stuff that we want, on our inclusion criteria, which I'll show you in a second. So the whole thing is kind of arbitrary. We made a set of inclusion criteria, and then we said, can we pick out patients like that? So I don't know why that X should have come up later. You'll forgive me in my slide making. But we required patients to be 48 or older. We at first said they had to have infiltrating histology, and then later, then later on we said that they could have DCIS. We added that later. They couldn't be pregnant or lactating. They couldn't have previous cancer, no neoadjuvant chemo. They couldn't have significant LVI. And then here are the critical things. They had to have a lesion that was 30 millimeters by mammography, ultrasound, and MRI, and final pathology. So the truth is, if we wanted this to succeed, we might have said, let's limit the size on imaging to 20 millimeters and on final pathology to 30. But if we allow a 30 millimeter lesion in on MRI, there's a reasonable chance it'll be 35 millimeters, on final pathology. So if the lesion was bigger than 30 millimeters, then what we did was we add external beam radiation therapy, and the IRT becomes the boost. The second important criteria is that they had to be lymph node N0. They could be I positive. If it turned out in the operating room they had a positive node, the IORT was canceled. We're going to change that now, and we're going to use the IORT as a boost in node positive patients. But the patient got canceled if they had a positive node. And if The node wasn't known positive in the OR, but we found out a few days later on permanent sections. Then they got external beam whole breast radiation therapy. We also required that the final margin be 2 millimeters. That was tough. And if it was less than 2 millimeters, we either radiated or we re-excised. We radiated if it was clear, but less than 2 millimeters, and we re-excised if the lesion actually had ink on tumor. And then after we re-excised, if there was no residual disease, they didn't get any radiation therapy. If there was residual disease and it seemed significant and the margins weren't widely clear, then they got radiation therapy. The second set of endpoints was safety, side effects, complications, and cosmesis. And this was where we ran into our first problem. And our first problem is called tungsten. Anybody aware of the tungsten problem we had? A few people. I'll tell you about it. So originally, there was a tungsten impregnated shield, this rubber shield here. And this shield would be cut to the right size and put on the chest wall, and then IORT would be given. And we started in around June or July of 2009, and by December we had done 27 patients, and per our protocol, they started coming back at month 6 for mammography on the IORT side. And here is a mammogram. Hard to see maybe in this light, but if you look really close, you'll see a bunch of teeny white dots on the chest wall, and I blow it up for you. Now you can see them easy. They don't look like the casting kind of calcifications you see in a bad DCIS. They're all pretty round and punctate when you look at them closely. That's one case. Here's another case in an augmented patient, and you see all these little white dots are lying on the pectoralis major muscle. And in addition, you can see some of them are coming out probably toward the incision. They're hard to see there. You can see there, here, this little arrow will show it to you. So the first patient came in like this. We assumed this was an artifact related to what we did. We did not know. We had no experience with it at all. So we threw her on a stereotactic table that day and biopsied her. And this is what the biopsy looked like. Some normal breast tissue and a bunch of little irregular objects in there, which our pathologists thought were metallic. So we immediately were worried about the shield, so we did a lot of things. We got some shields, we cut them, we rubbed them on X-ray film, we took X-rays of it, we got them wet and did it. Finally, here's the bottom line. The only thing when they got wet and you rubbed them on a piece of X-ray film and you developed it, this is what it looked like. Okay, you got a whole bunch of these white dots showing up. So they were clearly the problem. So then the next thing we did was we took that shield and we just went down and made a frozen section of it, and that's what it looked like. And the frozen section of the shield looked just like the little black dots in the patient. Then we sent these biopsies to a heavy metal lab, and in 3 days, we confirmed they were tungsten. So we were screwed. You know, we're in trouble here. So here's what we did. We reported it to the company immediately. We reported it to the FDA. We suspended the trial. We stopped the trial. We had the product got withdrawn immediately by the FDA. We called each and every patient, talked to them over the phone, called them in person, explained it to them, gave them all the tungsten literature we could find. We got a heavy metal expert clinician at UCI and had that person see every patient that was willing to see them. And we drew blood and urine tungstens and followed all of these things in all the patients. We waited 9 months for a new stainless steel shield, and when it got developed and approved by the FDA, we started using it, and in the interim, 15 of the 27 patients sued us. And 2 of those patients were talked into mastectomies by their attorney, saying that the case has limited value if you don't have a mastectomy. It has a lot more value if you do. And there was an internist who said to patients, get the poison out of you, this is a bad thing. So 2 patients did get bilateral mastectomies. Nothing was found. There was no residual cancer, and they had mastectomies and got reconstructed, and the suits are all still pending. Nothing's been settled. It's still there. Zoff did step up and send the CEO down to Hoag to talk to all the doctors, and Hoag and Zoff did indemnify the hospital. But the hospital still is sort of hurting from having this episode occur. Nevertheless, we moved on, and we color code in the operating room. We x-ray in 2 views to make sure that we've got the thing. Okay, so then you end up with a patient who looks like this. Patient has a hole. We kind of undermine a little bit. We've taken, you can see right down to the chest wall and including the fascia. So we feel quite secure with the deep margin and the anterior margin. And then we put the shield in. This is the old tungsten shield that fit in there. Once we put a shield in, we then put a series of large number 2 Ethelon sutures in. These sutures in the older cases all come out through the skin, but in newer cases we've put them where they come out under the skin. You don't have to actually come through the skin, although it doesn't really matter, because in the end it all looks about the same. And here's a balloon. We test the balloon before we put it in. Here's the balloon in the patient, and then these 2O Ethelons are tied, and we wrap the breast tissue completely around the balloon, closing it in front of it and behind the balloon, so it really becomes a sphere or a little smaller ellipse. Then, of course, you ultrasound from every direction, and you prove that you've got hopefully a centimeter or more in every direction. But we've gone down to as low as 7 millimeters without having too many problems, but I will show you a few of the problems. And then we measure the distance, and when everybody's happy with it, we put the whole thing together. We try to stabilize the balloon. If you look closely, there's an obturator in there, and that obturator has some marks on it. We can tell the length of the obturator, which is important for the treatment planning. We know the size of the balloon, and we know the fill volume. Once we know all those things, it goes into the program, and we know how to treat. Then at the end, we cover up the patient with the lead. Everything gets draped. The machine gets rolled in and connected up. And the radiation source is pushed down the balloon. And here you can actually see how the smallest person in the room can move this machine around. It's very easy, very mobile. And you're seeing it essentially almost in real time here. It snaps up. I would say we hook up in a minute most of the time. About 1 minute, we just hook up. And then there's a test where we want, that thing is testing to make sure it will go down and back. Once that test works, surgeons are out of the room. The radiation oncologists pull the proper program, they plug it in, and the machine does it. Most of our cases, I'd say the shortest case we ever had about 8 minutes, the longest case been about 18 or 19 minutes, which is about a half to a third of the time of my cases at USC with the other machine, and this was really profoundly convenient. So you might say, what do the surgeons do during intraoperative radiation therapy? And this is the answer, the definitive answer. They look at their little machines. So at the end of the case, we pull out this shield. At the end of IRT, you can see that the strings have made a mark. You'll see that the marks are all going very quickly. Here's that patient 1 day post-op. Here's that patient 6 days post-op. Here's another case using a radial ellipse, a little small tumor in the upper outer quadrant. Just a radial ellipse takes it out. There's the hole, but now we've got new and better stainless steel shields. Here you can see the stainless steel shield in the bottom of a cavity. Here's that patient 1 day post-op. If you look closely, 1 day post-op, you'll see the little holes where the strings went through. You'll see sometimes, in probably most cases, there's a teeny bit of redness here which disappears very quickly. Not in everybody. I'll show you the ones where it didn't. There are 5 cases where we had significant redness or burns. But that's out of 188 patients treated. 12 patients didn't get treated because they had positive nose. So there's that patient 8 days post-op. Little oncoplastic stuff. Here is a patient with a tumor in the 12 o'clock position. We'll take it out using bilateral crescent operations. Here's the specimen. Here's 2-view mammography. Here's the shield going in. There's the shield in the patient. There's the 2O ethylon, or the number 2 ethylon sutures. And in this case, no particular reason why I did this. I put the balloon in through the axilla because it was just a straight shot, but you don't have to do that. I'd say I seldom do it that way. Here you can see the balloon, the top of the balloon in the patient, right there. And then it's all hooked up, same exact thing we did before. And here's this patient 1 day post-op. Now, I do want you to look right around here because she does have a teeny bit of redness right there. I'll take the black line away and you'll see. It's not much, but it's enough to know it works. I actually like to see a teeny bit of redness because here she is 11 days post-op and there's virtually no redness there. Here she is 6 weeks post-op. So again, this is a good oncoplastic case. The tumor's out. She looks better than when she started, although I think she looked good when she began. And she's had her radiation therapy. So she leaves, and all she's got to do is deal with the medical oncologist, whatever they want to do. Here's one other crescent excision. Now, 5 cases have had burns like this. At first, the first time you see it, you say, oh, this lady's infected, and you put her on antibiotics. But she doesn't really get better on antibiotics. So once you've seen it a couple of times, then you know what this is. We've had 5 burns. They're all in older patients. They're all in people who are 4 out of the 5 are 70 and older, and the other one is 65. So they tend to have thinner skin. We thought they might be in the less than 1 centimeter balloon to skin distances, but they were all about 1 centimeter. So it wasn't that it was too thin. But so this is 3 weeks post-op. Here's that patient 6 months post-op. A lot better, not all better. And here's that patient 1 year post-op. You can still tell it's there. She's not unhappy about it. We're unhappy. We don't like it. But it's going to happen. There's not any way that you can do all of these things and not have some little minor thing. So this has happened 5 times. Here's that patient from the front. She looks absolutely perfect. Now I'll show you the worst case. This lady was, I think, 78. And there she is at week 1, week 2, week 3, week 5. And week 5, I think, was the worst. Week 6, and it was getting better. By week 6, you started to see this looking a little bit better. And then by week 8, she was better yet. And then she stopped seeing me and just sees the radiation oncologist. So she clearly must be better because they don't really know what to do anyway. But I know she's better. I know she's better. An oncoplastic case, large woman with a tumor in the lower inner quadrant of her right breast. Here's the x-ray of it. Here's the MRI, unifocal. This is a perfect case for IORT. So here's the plan. We're going to excise that area in the lower inner quadrant, and there it is excised with the tumor. There's 2-view mammography with yellow arrows looking at the clip. Here's the hole. We put a metal shield in. We put a balloon in. We tie it all up. We ultrasound her. We make sure it looks good. And here's that lady 6 days post-op. Can you tell? I don't know. There's a little black and blue. I don't know that I can tell that there's any redness there. But here's the lady 1 year post-op, a perfect result without the significant changes of whole breast radiation therapy. Plastic surgeons love this because they know they can count on the result to stay. There's not going to be breast edema, and there's not going to be shrinkage of the breast. Here's another standard reduction, lower outer quadrant tumor. Day 7 looks perfect. Here's another one, another more central tumor. Day 8 looks perfect. Here's another standard reduction, the opposite breast, 1 year post-op, looks perfect. So this is really, if we can do this, this is the treatment of the future for me. It's excision of these tumors using a reduction, 1 dose radiation therapy, done. And then let the medical oncologist deal with it. Here's our split reduction where we're taking an extra piece. So the split reduction is really like an ellipse. We just take out that piece up there and then do it like an ellipse and then complete the reduction. So there's the specimen, there's the hole. Here she is with her shield in. Here it is all put back together, tied up. Here she is 1 day post-op, and there she is 6 days post-op. And then this case, here she is 1 year post-op. Again, I would challenge, is there a teeny bit of redness? Maybe there is, but this is about as good as we're going to get. Here's some other split reductions where that's where she was treated. Here's another split reduction, here's another one, so you can see. And then what we just did a couple of weeks ago was a bilateral split reduction. We tried this once before, but the time before a patient had a positive node, we had to abort it. But this time we didn't have to abort it. So this lady had 2 cancers, as you can see. And we were able to take both of these cancers out through the top of the keyhole. So, and do IRT at the same time. So there are the 2 excisions. And here she is. We didn't know how to do this because we never did this before, but we put the catheter in on both sides, got it all set up, and then the radiation therapist went from one side to the other side, and we put lead shields on both sides and treated her, and there she is 12 days post-op. We were going to have a 30-day post-op, but she failed to come the other day. She was so happy. And now the place where I think this really works and is fabulous is in the augmented patient. So here's an augmented patient with a tumor up there. You can see it on X-ray and on MRI. And so here's the plan. It'll just be kind of a round Benelli with a little split on the top. That's how we'll take this out. So there it is coming out. And there's the specimen, just like we drew it. And now you can see the implant in the base of her breast. We're going to pull that out. It's an old grungy implant, and we'll replace it. Generally speaking, we pull the implant out, treat, and then replace it. In this particular case, there was enough breast tissue, we decided not to replace the implant. But most of the time we do, and I'll give you the exact numbers. Now, she has a great big hole there from the implant. So what we have to do to keep the shield from moving, the shield would be better if it had a little hole in it, a little lip on it with a hole that you could sew it in place, but I can't. It's a round thing with no hole. So what I'm going to do is put these sponges over in the corner there to hold the shield where I want it, and then put the balloon in. And there's the balloon going in. And there's that patient treated. Her implants were not replaced. But here's a patient, and there she is 6 months later. Here's another patient that we just did, an upper central tumor. We took this out with a Benelli ellipse type operation. You can see the big hole we make. And there she is 8 days post-op. And you can see how the Benelli and the changing of her implants makes it better. She may not be perfect now, but she's better than when we started, and she's had her IORT, and she's not going to get capsular contracture around her implant. And here's a longer-term patient. This lady has an upper central tumor on the right-hand side, and it's now 1 year post-op. If you look really closely, there's a teeny amount of skin color change, just a teeny bit, but she's thrilled with that result, and it's far better than anything we'd ever get if we gave her whole breast radiotherapy. One final case, this lady is 5 years post-op. I did her at USC with the other system, and she had an upper outer quadrant tumor, augmented breast, made no sense to radiate her whole breast. We excised that tumor and radiated the upper outer quadrant. Now, overall, I looked this up before we came. We have 26 augmented patients at Hoag that we treated with IORT. In 24 of them, we saved or replaced the implants. In 2 of them, we removed the implants. 8 patients failed one or more of the pathology criteria and should have either gotten whole breast radiation therapy or re-excised, but it ended up that only 2 got re-excised and 1 got whole breast. And I'll explain why everyone doesn't get all the treatment, because you have to understand the protocol is kind of flexible. So here's the Hoag data. We tried to accrue 200 patients. over a couple of years, which we did. 4 surgeons did 200 patients. And we finished accrual in mid-April of this year. 12 of those patients were not treated in the OR because of positive nodes, so 188 got treated. And then there's another 18 additional patients treated off protocol. These are people who were 1 year too young or some little minor thing that we agreed to treat them. And we won't discuss them now. But so of these 200 patients, 64 of them failed one or more pathology criteria. That means node, size, margins, or extensive LVI, like I outlined in the beginning. And this is really interesting. Here's who failed. The invasive lobulars, 63% of them, they're hard to get clear margins, and they're often bigger than you think. Large DCISs, 4 centimeters or more, or invasive ductals with big DCIS components, 45% of them failed. Who didn't fail? Invasive ductals without much DCIS, only 20% of those failed, for an overall failure rate of around 33 or 34%. So 33 people failed margins, but only 4 of them actually had ink on tumor. So the truth is, if we were in the target trial, we only have 4 margin failures because the other 29, they don't fail based on the target criteria. And of those 33, 17 declined re-excision or whole breast. They didn't want it. They looked at the data. They said, if I was in a different trial, I wouldn't be getting whole breast. And 16 accepted some additional treatment. 5 people with close or involved margins had mastectomies, and 2 of those 5 mastectomies had residual disease. And I'm not counting the other the mastectomies done for the tungsten. So that means 7 patients out of the 200 had mastectomies, which is not bad. 2 tungsten patients had mastectomies, we said that. And recurrences to date, none. So I think I ought to stop because I've gone over my time. And I think I have other things to tell you, but it doesn't matter.
Thank you, Mel, for a